Wonderful. So this is just a quick little bit about me. I think anytime I hear a talk, I like to know who's giving it and where are they coming from so I can understand their perspective. So I'm Mike Cooper, really happy to be with y'all today. I'm the Vice President of Medical Affairs at Norfolk General Hospital right down the street. I'm an Associate Professor of Medicine at Eastern Virginia Medical School. I did all my medical training at Vanderbilt. I did medical school there, residency in internal medicine, and then a fellowship in pulmonology and critical care medicine, and then did a master's of science in clinical investigation. So understanding how to design clinical trials and carry out clinical trials. Did that for a couple of years on the tail end of my training. And then my wife, Brooke Cooper, who's also part of the church, of course, was with the Navy and took a job at Portsmouth Naval Hospital, and that's how we ended up in Norfolk. Very happy to be here and have really put roots into this community and enjoyed being a part of the church and enjoyed being part of the Ghent and Norfolk community. It's really been fulfilling and has kept us here long after our Navy obligation has ended. So I'm here to talk to you today about at least my opinion or my reading of the tea leaves in terms of what lies ahead and my understanding of that based on history, science, where I have formal training, and then faith. The view in the background here is, I think, really representative of how we've been living 2020. So this close-up microscopic view of a pandemic, thinking about COVID, thinking about respiratory disease, thinking about masks, thinking about how far we are from each other, trying to relive and re-understand how we should interact with each other safely. It's been very disruptive and I think a hard thing for all of us to be a part of. I think part of understanding this and part of understanding where we go from here involves getting that perspective where we back off of the experience that we've had in 2020 and understand things in context. So as we zoom out from that microscopic view, I think we can get a better look at how this pandemic, how this disease, how last year and the beginning of this year fit into the context of our lives and the context of our society. And as we zoom further out, I think you can see that you can gain a new perspective and you can kind of see life as it is. As we zoom out from the bark of that tree, we can see the environment around us. And that's what I want to try to do in this talk. I'll start with a zoomed in view, talking about my understanding of COVID, my understanding of where it came from, my understanding of what we lived through, and then try to use that in the context of our whole lives and our whole history and where we're going to go from here. So the virus that we dealt with last year is called SARS-CoV-2. This is a zoomed in microscopic view of that infecting the cells in a human host. The disease it causes is COVID-19, which is largely a lung disease, but also affects other organs, namely the kidneys, and makes people very sick with a septic-like illness that's life-threatening. If you look at coronaviruses in their family tree, this is what it looks like. And there's several related diseases that we've all probably heard of. There's MERS-CoV, which is a Middle Eastern respiratory syndrome that has affected people in certain parts of the world. There's the first SARS-CoV virus, which came out in 2003, infected people in Asia and then infected people in Canada and North America, and gave us quite a scare. And then there's the other four abbreviated, non-bolded diseases, which are coronaviruses that we all live with and that cause common colds. So this family of viruses is where SARS-CoV-2 came from that gave us the pandemic that we're living with today. So if you look at the timeline of what we went through last year, December 31st of 2019 is when China first reported dozens of cases of pneumonia of an unknown cause. In January 11th of 2020, we saw China report its first death from this pneumonia. And January 20 to 23rd, we saw Wuhan, the large city in China, locked down as they tried to control a spreading epidemic within their borders. The World Health Organization declared this a global health emergency January 30th. We started seeing frequent news reports. There was a lot of concern, but no one knew what to expect. February 7th, there were widely published reports of a physician, a young physician in China who'd first tried to raise alarms about this disease process. He passed away in a Chinese hospital from acute respiratory syndrome caused by COVID-19. February 23rd is when things really started to shake the Western press. Italy saw an enormous spike in cases that gave everyone a lot of pause, and it started to become clear that this was going to spread in Europe and likely come to the United States. Many hospitals, health organizations in the US really started to turn their attention and their focus into what was going on across the world. February 29th, the United States on the West Coast reported its first death. And then March 15th, the CDC recommended restricting gatherings to no more than 50 people across the country. Schools started to close, businesses started to close, and we started to try to figure out, what are we going to do now? One of the scientific studies that was really informing public health policy at that time was an Imperial College of London report that looked at populations in the US, populations in the UK, and were extrapolating the early data that they were seeing coming out of China. And based on death rates and comorbidities in patients in different age groups, they put out this table that made its way through health systems in the US. And their prediction was that in the US, with a population of 308 million, that at current rates in China, that we should expect to have about 2.3 million deaths over the course of the next year if we didn't have a coordinated pandemic response that went into place. That included some deaths in younger people, but really clustered heavily on people in the age greater than 70 category, where they were expecting 1.5 million people to die over the course of the next year if we didn't do something about it. So it's really hard to look at this kind of data and not get on board with a coordinated and quick response. So what were we weighing? Millions at risk of death, millions more at risk of serious injury and hospitalization, the risk that we might overrun the healthcare system, and suspected many additional deaths secondary to that. We knew at that time that there were no proven treatments. We knew that the disease spread extremely rapidly. There were multiple reports in the US and in Europe of single individuals carrying the disease and infecting dozens of other people and leading to severe illness and deaths. There was a severe shortage of supplies that began to be noticed in US hospitals as people began treating possible patients and began suspecting with every patient that came in with a respiratory illness that they might have this disease. Mass supplies began to dwindle, and it began to become apparent that we were going to run out of supplies. In the course of March and going into April, there were actually advisories that came out from the CDC, the public health agency in the richest country in the history of the world, that recommended that healthcare professionals use bandanas or other pieces of cloth as masks should we or when we run out. At the same time, we were weighing the certain dramatic negative economic impact of shutting down businesses, shutting down our places of work, and how are we going to deal with that? There was the concern of social isolation, depression, mental illness if we stopped interacting with one another. There was the educational impacts that everyone had concerns about as we took our children out of school. We knew that we would be disrupting social services to people that depended on it, the vast number of people with mental illness, the vast number of people that required nursing care, required personal care. How are we going to continue to do that? And then there was the supply chain disruptions expected in multiple industries, and the predictable risk and impact that that would have on health and our economies. So we all started to make risk benefit calculations, whether it was city councils, companies, people, churches, governments. How are we going to weigh these things, and how are we going to get through this? This was the graph that started to go around on Twitter, where public health experts were trying to explain as simply as possible why we have to do some of these things. The concern was that without doing some things, that we would break the healthcare system. So if millions of people became infected at the same time, and then 10% of those people showed up at hospitals for extended periods of time, then we would overrun the healthcare system capacity. And when we do that, we knew that there would be additional preventable deaths due to the lack of services. So people coming in with strokes and heart attacks and car accidents and regular pneumonias and all the other things that we normally treat would no longer have services. And indeed, we are seeing this play out in other countries. In Italy on March 16th, only a day after the CDC recommendations to limit guidance, there were news reports of hospitals in Italy saying that they were no longer going to put people over the age of 60 on ventilators in order to retain those services for people that they could save. So that was something that we obviously wanted to try to prevent having happen here. Furthermore, we knew that if we could buy time, that we could develop treatments, develop vaccines, and thereby prevent infections that would otherwise happen over the natural history of this pandemic. So that was the goal, that was the stated goal, and that's what we are trying to operationalize across the country and indeed across the world. And when you look at some of the early data at countries that were hit hard, it did indeed show that those healthcare systems that were stretched suffered. So this is data that came out of a United Kingdom study where they had thousands of people requiring critical care admissions. And just to give you context, Norfolk General, which is the tertiary care hospital servicing a 1.5 million person catchment area, has about 80 critical care beds in its hospital. There aren't that many hospitals in Hampton Roads, so it's really hard for a healthcare system to take on thousands of critical care admissions in a relatively small area. And what this study showed was when they were stretched, when they had critically ill patients in other parts of the hospital, when they were having staff take care of many more patients than they were used to, the risk of those patients succumbing to the illness was significantly higher than later on or in the early parts of the pandemic when they had much fewer patients. So as we learned, as we were able to protect the most vulnerable, as we were able to protect the healthcare system, we were able to save lives. And that is indeed what we wanted to do. So the recommendations to flatten the curve to try to prevent the healthcare system from being overrun were relatively simple. Don't gather with large groups of individuals. When you do gather or need to gather, keep your distance, wash your hands frequently to try to prevent the spread of disease. And then eventually in the month of April, recommendations to try to mask to prevent the spread of this respiratory illness from going from one person to another when you're sharing air in a closed ventilated space. So this is the curve that played out over the course of that next year on that timeline that I showed previously. Now it's a little bit deceiving. This curve shows confirmed cases of COVID-19. Every red bar here is a week of data that came in. The dark red line is that 7-day average of the number of cases in the United States as we went through the initial phase of the pandemic, as we saw the summer surge, and then as we saw the winter surge over the course of the holidays. But this really did not show the actual number of cases that we were dealing with in the healthcare system across the country, because early on in the pandemic, we were unable to test. We didn't have the testing supplies, we didn't have the testing machines, we didn't have the testing capability. And so in New York and Michigan and New Orleans and some of the areas that were hit hard very early on, there were a large number of patients that never had confirmed illness, but we know by the number of people that came into hospitals and the number of people that died that the number of illnesses was significantly larger. And so if you were to predict out what those waves of infection look like, the economists have graphs that looked more like this, where we saw a large spike in illness. We then had restrictions in the way we interacted with one another. That went down. In the summer surge, when people began to relax some more and some of the economy opened back up, those illness numbers went back up. And then in the holidays, when people began to gather indoors, we saw that illness spike once again. The mortality rate over time drifted significantly. So early on in the pandemic, the numbers coming out of Italy suggested that 10 to 12% of people who are infected might pass away from COVID-19. Some of the early reports from China estimated 5 to 15%. But as more data came in, it became clear as we were able to test more and saw the true extent of the disease, that the risk of illness or the risk of death from illness was significantly lower and likely closer to around 1% or 0.5% of people that were infected with the disease. The Lancet, a British medical journal, took a large number of cases and broke it down in a more granular way. And what they did is they broke it down by men and by women. They broke it down by age group. And then they broke it down by the number of underlying medical conditions that that person had chronically, and showed that the risk of death from COVID-19 was significantly different by age and by underlying medical conditions. And we knew this very early on, but the numbers continued to prove this. And so if you were 30 to 55 years old and had no medical history and you got COVID-19, only about 0.12% of men in that category, or 0.07% of women in that category would actually die from their illness. On the other extreme, however, if you were in your 80s and had 3 or more medical conditions, meaning hypertension, diabetes, chronic lung disease, or were immunosuppressed, then you would have a nearly 1 in 3 chance of passing away if you were to get COVID-19. But as we were armed with this granular data, as we began to protect the people that were most vulnerable, and as we began to see the overall death rates were considerably lower, the question became, what is the risk and benefit to the different restrictions we have in place, and what are we going to do now? And what you saw play out what we all saw play out in the media was sometimes a very discordant or fear-mongering type of approach, and a lot of arguments between people with extreme views. But what we really started to see play out across our country and across all countries is that public health professionals and medical professionals defined what the medical risk was to the population. They defined what the mitigation of medical risk with certain measures was, and they defined what the unintended health risk with certain measures were. You then had economists and business leaders who were quantifying what's the financial risk, what's the job and industry impact from this, and what's the financial risk of certain restrictions. And then you saw politicians and the general public trying to figure out what's the assessment of those risks and benefits, how do we put all that together, come up with policy decisions that make sense, and come up with personal decisions to protect one another. And so what next? We saw a successful mitigation of risk with standard respiratory illness precautions. We saw mortality lower than initially thought. We saw that we still had a risk of an overrun health system if measures were fully relaxed, so we knew we couldn't do that. We saw that some mildly effective treatments were in play. So in the hospital, we knew that we could use steroids to save lives. We saw the drug remdesivir come onto the market, and we saw improvements with that. We saw certain types of plasma or monoclonal antibodies that were put into circulation that were effective. And we saw many other treatments tried with some encouraging results. We also saw incredibly encouraging vaccine data coming out in the fall. We became increasingly confident that by the end of 2020, we were going to have vaccines that we could offer to the general public, and that we could begin to offer to protect healthcare professionals and protect our most vulnerable people. And we saw our supplies significantly improve. So physicians, nurses, respiratory therapists didn't have to worry by August and September that they were going to go take care of people and not have the protective equipment that they needed to protect themselves. We saw that the general public had access to masks, access to cleaners, access to the things that they needed to mitigate their own risk. We also, on the flip side, saw that dramatic negative economic impact. We saw the impact of social isolation, depression, and mental illness that came from being isolated. We saw some of the educational impacts on our students, and we saw some of the success that we'd had with virtual learning. We saw disruptions in social services, and we saw that some industries had successfully adapted to the changes in society. And the question became, what does the future hold? And I think what we also begin to see is that people started to put the current pandemic and its risk into context. And one great article that I saw come out in The Economist looked at Johns Hopkins estimates for COVID-19 and began to compare that against historical estimates of the impact of other pandemics that we had seen in the course of our lifetime and in the course of human history. So this is one infographic that came out. And what this current slide shows is of the respiratory diseases that have hit in modern history, this is how COVID-19 stacks up as of March 2021 against Asian flu, Hong Kong flu, swine flu, MERS, and SARS, the other pandemics that we have seen. And what you see is it's been more impactful. It's had a much bigger impact and will continue to have a much bigger impact than any other respiratory disease that we've seen in our lifetime. If you include other pandemics in our lifetime, non-respiratory, you see HIV had a much bigger impact in terms of loss of life. I think Ebola is also another one that has hit the list. And those were both scary and concerning in their own right. I think We didn't see, at least in our lifetime, the same concern around HIV because it was very well understood what you could personally do to prevent it. Ebola was largely sequestered on another continent, and we were successful in containing that pandemic or epidemic, I should say. But when you begin to compare back against other epidemics and pandemics in human history, you see that humanity has suffered far worse. So if you look at the Black Death or bubonic plague, 200 million people died as a result of that, which was roughly at the time half of the population of Europe. You saw 56 million people die as a result of smallpox, 40 to 50 million people die worldwide as a result of the Spanish flu, and other plagues throughout the course of human history have also had sizable effects. I think we've seen other tragedies that people have endured. So these are pictures from the bombings of London, one neighborhood there, and shows people walking in the aftermath. These are bombings in Germany happening at the same time in retaliation. And you see some human resilience as people are getting on mass transit, even in the midst of this rubble. When you look at graphs of wartime going back to 1500s and on, you see that from 1500 to 1800, the majority of the time, major powers across the world were at war with one another. And that's something we've largely been spared of in the last 70 or 80 years of human history. The result of those wars is dramatic. If you look internationally at battlefield deaths in the 1900s, you see huge spikes in deaths per 100,000 people as a result of wartime. To compare that, what we've seen in the US, the same rate of death from COVID-19, it's fairly small if you compare us to what occurred worldwide versus World War II, for instance. So what's the point I'm making? Well, the point I'm making is if you zoom out from the context of COVID, from the context of 2020, this is something that we can and something that we will endure. I think we all understand that. If you look just at the history of germs and microbiology and go back to COVID, I think it also gives us some additional context that's important to remember. So this just looks at the history of germ theory. If you look at early history of our understanding of how diseases spread, the ancient Greeks had a miasma theory of disease, which looked at disease spreading from one entity to another through rotting organic matter. Persian physician first described epidemics. A German physician first described microscopic pathogens and attributed diseases to that. A Hungarian physician in 1847 first attributed maternal mortality from febrile illness, which was sepsis, and was able to come up with an intervention, which was hand washing, to prevent a large number of disease. John Snow, around the same time, traced a cholera epidemic back to a single well and figured out that boiling water and shutting down that well could interrupt that epidemic. If you look in the 1900s at infectious diseases and its impact on human life, what you see is that with our simple understanding of germ theory and our interventions with clean water, interventions with infection control, interventions with early antibiotics, and then interventions with vaccines, we've made a dramatic effect on how infectious diseases impact human life. In 1900, the top three causes of death were pneumonia, tuberculosis, and diarrhea. Infectious diseases that were largely preventable, but that were largely misunderstood. As we begin to understand that, as we begin to use simple interventions and medicine to try to intervene on these things, we had a dramatic effect on that. And when you look at the top causes of death now, infectious diseases don't even get onto the list with any meaningful amount compared to heart disease, cancer, stroke, or the other things that we spend our time in medicine worrying about. The impact on life expectancy across continents from understanding and containing infectious diseases has been dramatic. We've seen average life expectancies go from the 20s and 30s up to the 70s in most developed countries. Viruses are all around us. So if you take 1 liter of seawater, it has about 100 billion viruses in it. Most of those cause us no ill effects. In a single teaspoon of soil, there are about 1 billion bacteria. In a single gram of dental plaque, there are about 100 billion bacteria. There's over a quadrillion viruses spread across the earth by estimation, and somewhere around 100,000 different viral species. 8% of our DNA is estimated to be remnants of viral DNA. And really, when you look at the course of human history, we live in constant interaction with the microbial world. And it's not something that with our current tools, with our current understanding, and with our current medical equipment, medical industry that we need to fear. This shows total deaths in the US over time, looking at the flu pandemic and the COVID-19 pandemic as outliers. This is not something to be discounted. We've seen a 15% increase in the number of expected deaths in the last year. And that's not something to minimize. But when you look at that over the arc of human history and look at the death rate in the US over time, what you see with the COVID-19 pandemic in 2020 is that we've had death rates similar to the year 2000, despite this increase. And that's not to minimize or overlook the tragedies that have occurred as a result of this, but it's simply to zoom out and put it in the context of the arc of human history and the progress that we've made in medicine, the progress that we've made in public health over time. The best prophet of the future is the past. And as I look at this graph and look at the improvements we've made, clean water, sanitation, adequate nutrition, antibiotics, modern medicine is things that have reduced this death rate so substantially over the course of time. I have faith that we're going to continue to do that, not only with this disease, but of diseases that we face in the future. So how do we get over this? What's the science behind it? What do we have to do as a society? And what will this mean for us in the future? So we all have heard about herd immunity and what we need to do to reach collective herd immunity. We've had about 60 million people likely infected with COVID-19, and we've been vaccinating people now since December. What this table shows is 3 studies that occurred very early in the pandemic, one in Bahrain, one in Spain, one in Sweden, that showed the reproductive rate of the virus, which meant how many people after one person is infected with the virus would become infected as a result on average of that single person. And what they showed was somewhere between 3 and 5 likely was representative of the rate of infectivity of this virus given normal human behavior in a Western society. And so what does that mean? What percent of the population would need to be immune if we were going to eradicate this based on that rate of infectivity? And then how many people in the US would need to be immune to make that happen. And if you do the math, we need about 260, 250 million people in the US to be immune. That's a significant chunk of our population. And the way that we get there is through vaccination. And what we see is that at this reproductive rate, and this graph shows a reproductive rate of 3, a reproductive rate of 2.5, and a reproductive rate of just less than 2, over the course of a very short period of time, how many people would become infected from a single individual. Fortunately, we have vaccines that work. And I wanted to describe a little bit about how vaccines work in general and how these vaccines work, because that is our path forward, and that's how we get back to a normal life. So these are the different ways that vaccines can be developed, the major buckets by which we have been able to develop vaccines in the future and in the past. So in the past, if you look, say, at polio vaccine or at most of the vaccines that we have had over the course of our lifetime, we have either taken an inactivated virus or have taken a live attenuated or a live weakened virus, manufactured that, and then injected that into people to elicit an immune response and protect them from a disease. What we've seen developed over the course of the COVID pandemic is multiple other approaches to try to more quickly develop a vaccine and be able to mass produce a vaccine so that we could interrupt this pandemic considerably more quickly. So these are the two types of vaccines that we have seen come into production across the US. So an RNA vaccine was developed by Pfizer and by Moderna. A viral vector vaccine was developed by Johnson & Johnson. The vast majority of the US population has received the mRNA vaccine. This is a complicated diagram that shows how that vaccine works. What you see at the top is a yellow circle, which is a lipid nanoparticle. So think of it like a soap bubble containing a small amount of genetic material, which is messenger RNA. That is what is injected into your deltoid muscle. It then enters cells. That red squiggly line there is that messenger RNA or genetic material. What your body does with that is it takes that small amount of viral genetic material and then produces viral proteins. The spike protein, which is the signature protein on this virus, which your body needs to recognize in order for immunity to be produced. It takes that spike protein, that goes through your cell, and you then generate immune cells and antibodies which can react to that spike protein should you encounter the real COVID vaccine or COVID virus in the future. What we saw in trials is that this vaccine was nearly 100% effective in the prevention of death or hospitalization from COVID-19. It was 90 to 95% protective against developing any symptomatic infection with COVID-19. And it's been shown subsequently to greatly decrease your risk of infecting other people if you are to obtain the vaccine. These results are exactly what we hoped that we would get from this, and was really fantastic news when we saw this hit the press and hit the medical literature in late November and early December. So the path to an mRNA vaccine is really interesting. I won't go into too many details because I know we're running short on time, but mRNA was first discovered in the 1960s. We knew in the 1990s that this would be something that would be useful for therapeutics, but it took a couple of decades for some of these companies to take this and figure out how to use this in a way that, that was effective in the body. Moderna, which is one of the companies that developed the vaccine, actually means modified RNA. It's a combination of those two words, and that is where they derive the name of their company. In 2018 is when we first saw lipid nanoparticles, or these soap bubbles that house the vaccine or house the RNA, that were able to allow this vaccine to come to market. This is a timeline out of a medical journal that shows how long historically it has taken us to develop vaccines. And what you see on here is typically it's taken us 3 to 8 years to figure out the science, 2 to 10 years to do the trials, and then 1 or 2 years to get the vaccine approved through the regulatory process. The fact that this takes so long historically is one of the things that hit the press, and one of the reasons that people were very skeptical of our vaccine enterprise and of the fact that we were able to figure out how to make vaccines so quickly. The reason that we were able to do this so quickly is that modern medicine, modern equipment allows us to gene sequence very quickly. Scientists in China had actually released the gene sequence for SARS-CoV-2 before the disease even hit the United States. Part of the reason for this was we had done decades of work on a cousin virus, SARS-CoV-1, which caused the initial SARS outbreak in 2003. The knowledge from that allowed us to figure out this pathogen and get that genetic sequence put into the scientific literature very quickly. Moderna was actually able to take that sequence and develop a preliminary vaccine over the course of only a few days. And they were able to do that fortuitously because they have developed this type of vaccine before, trying to come up with vaccine for Zika virus and for influenza. So over the course of 6 months, we saw phase 1 trials occur from not only Moderna, but also Pfizer and other companies. And then in a 3-month time frame, we were able to take that data, do large-scale phase 3 trials. And that was possible because so many people were getting COVID all at the same time. It made it very easy for the drug companies and the universities to recruit patients or recruit people that were at risk for being exposed to the disease. That's unlike for Zika or some other rare diseases where you had to vaccinate millions of people to find people at risk. In this case, it was much easier to find people at risk of disease. So one of the things that gives me hope about this whole endeavor is this lipid nanoparticle technology and mRNA technology is really incredibly revolutionary. The fact that we were able to develop an effective and safe vaccine in a very short time frame is something that gives me enormous hope for the future, in that we will be able to do this again for new diseases, and we will be able to do it quicker than we did even this time around, and we will be able to do it more safely with the experience that we've had this time around. Furthermore, it is almost certain that this technology is going to lead to revolutionary therapies in cancer therapy and multiple other genetic conditions. The ability to do this and do it safely, this has gotten us over the hump where incredibly important scientific research is going to come out of this work. So I wanted to show a graphic just to show how effective this vaccine is. So we talk about 95% effective at reducing cases. We talk about 100% effective at keeping people out of a hospital. But this is the actual graphic that came out of the medical journal for the initial Pfizer vaccine. And what the blue squares show is over time, after people were vaccinated, even getting their first dose, it shows people who were getting infected. So it shows of all the participants, what percent of those people were getting infections. In the red, what you see is of the people who got the vaccine, what percent of those were getting infections. And you see that even after a couple of weeks of the first dose, a pretty significant split between those people that got placebo or a saltwater injection, or those people that got the real vaccine. So I think that this is very important because it shows how efficacious in a graphic the vaccine really is in preventing disease. Real world data has shown us the same thing. So what you see in the graph at top is the percent of people from Israel, the United States, and India who have received vaccines. And what you see is Israel did an incredible job very early on at vaccinating their population. They were able to do this because they have a smaller, contained country. They also have a huge pharmaceutical industry there, and they were able to quickly distribute and administer the vaccine to a large amount of their population. The US has been catching up, but was slower out of the start, but able to also vaccinate a significant portion of their population. India, a very large country, many people below the poverty line, considerable more challenges in terms of getting the vaccine out to the population and distributing it. And what you see is the rate of change in death rates is that we've seen a huge spike week after week in India in terms of the number of people that are dying of COVID over this same time frame. We've seen the US plateau and even come down in multiple time frames. And we've seen Israel nearly eradicate the disease by vaccinating a large portion of their population. So the vaccine is effective, and that's what those last couple graphs were meant to show. The other thing that's in the press, and for good reason, is what are the side effects of the vaccine? And for the mRNA vaccine, there is a problem with anaphylaxis, people having a severe allergic reaction to the vaccine. This has been estimated to happen about 2 to 5 times for every million doses of vaccine administered. I will say we have seen this in Centera occur, but we have also given out enormous numbers of vaccine to the populace. For the mRNA vaccines, about 211 million doses have been administered. There have been about 3,400 people who have died in a short time frame after a dose. When you look at that rate of people passing away, it is not over what would be expected for a similar sized group of people who had not been vaccinated. So the scientific community feels very strongly that this vaccination is very safe and that we have done this very safely in our population. The adenoviral vector vaccine, or the Johnson & Johnson vaccine in the US, it's also called the AstraZeneca vaccine, is the European version of this. There has been a rare blood clotting disorder which has been linked to that vaccine. That appears in about 1 per million doses, and it may have an additive effect if you're on oral contraceptives. So there are some warnings out for particularly young women with that vaccine, but it has now been reintroduced both in Europe and soon in the United States in terms of administering that vaccine again. I wanted to give a little bit of a comment about variants. There's a lot of press about different variants and how they might be more risky in terms of how they spread, or they might be more risky in terms of their risk to you as an individual should you contract that. I just wanted to point out that there have been thousands of variants of the disease since the onset. And this is not a new thing. This has been occurring really since this disease first hit Europe and first hit the United States. It mutates not infrequently. What you see right here is a family tree, again, of coronaviruses. And every blue, yellow, red, green entry is a strain name for some coronavirus that has been sequenced and detailed. There have been countless number of variants. None have effectively evaded the mRNA vaccines that have been distributed widely in the United States. Some have been shown to be more contagious. The jury is still out on whether or not there's really a variant that's significantly more deadly in terms of its risks to you if you were to contract it. So, what are my predictions for the future? So I gave an enormous amount of background, but I think background is important. I think context is important, and that helps us talk about predictions and what are we going to see as we move forward. I think the first caveat to this is I'm a physician by training. I'm not an economist. I'm not a politician. And so how are we going to react to this, I think, is anyone's guess. I think I can make some predictions. I think they are the predictions from someone with scientific knowledge, but not necessarily predictive knowledge on human behavior. I think we're going to continue to be looking at the risks and the benefits moving forward. Now that we have vaccines for everyone, the risks are lower. Now that we have offered it to all adults, the ethical standpoint has changed significantly. So this are some odd pictures to have up on the screen, but let me give you some context. And my caveat is if you ask a scientist to develop clothing or to predict what clothing should look like, they would put things like this together. So they'd put together Gore-Tex when you go skiing. They would put together utility or functional pants so that you can carry stuff. They would put together scrub outfits for the hospital. But scientists can't predict fashion. And just like I can't predict human behavior in the pandemic, trying to predict what people will do is another story. So the fashion industry generates non-functional clothing. So much like they will take these risks and benefits and skew them differently, human behavior will not be predicted by scientists, but will be predicted by all of us together. My faith in human behavior and in human society is encapsulated by this video. So I will show this very quickly. It's a couple minutes long. And I saw a lot more of this type of behavior in the last few months, in the last year, than what we often see in the news, the discord between extremes. And so I wanted to show this because it informs what I think is going to happen in the future.
เขาจะได้อะไรถ้าเขาทำแบบนี้ทุกวันเขาจะไม่ได้อะไรเลยไม่ได้รวยขึ้น ได้ออกทีวีไม่มีใครรู้จักไม่ได้มีชื่อเสียงที่มากขึ้นเพราะสิ่งที่เขาได้คือได้แค่ความรู้สึก
So I think that might have been a little jumpy. So sorry if you couldn't see it, but I think as we intake the news, as we talk about what will happen in the future, it's very easy to imagine that humans aren't going to work together, that people aren't going to get vaccinated, that people will refuse to wear masks, that people aren't going to try to look out for the most vulnerable. But I sincerely believe, as I watch the way that we as a society, as a country, as a world have responded to the pandemic, that's not going to be the case. Our current status is that we have effective vaccines that are widely distributed. We have a significant number of people with natural immunity. We have vaccines available to all adults and almost half the population with one vaccine administered. We have a disease that rarely affects children and to which most of them aren't affected at all. We do have some vaccine hesitancy that's widespread, and immunocompromised people must be at risk. And so what are we going to see moving forward? Well, I think that we judge and juggle risk and benefit all the time as a society. We make decisions about speed limits that we know will affect human life. We make decisions about smoking that we know will affect human life. And as we look at the data from the last year, we see that the things we've done have worked. By masking, these graphs show that we essentially eliminated flu season in 2020 to 2021 by protective measures, by wearing masks, by social distancing. We were able to keep the most vulnerable out of the hospital from flu, much in the same way that we were able to keep many people from getting COVID. And I think that's going to inform what we do moving forward. I think effective, low cost, low inconvenience interventions are going to persist in some way, shape, or form. There'll be some changes in societal norms during flu season. People are going to be wearing masks if they're concerned about their own health. We're going to see health professionals likely wearing masks. There's going to be mandated mask use likely in some settings like the hospital. There'll be more emphasis on sick leave for certain types of symptoms, and there'll be replacement with virtual work or education when people are ill, have fevers, or might get other people sick. That's my prediction. I think there'll be very intensive monitoring systems put in place for infectious diseases worldwide so that we can pick up on pandemics earlier and have earlier interventions like what we saw in China before that spreads outside of their borders. And will a coronavirus impact our day-to-day lives in the future? I think this is the big question that's out there. And this is why I talked some about variants and I talked a lot about vaccine. And my feeling is that there is a low chance that some of these variants will evade our vaccine effort and immunity and will pose significant risk for recurrent infection. I think the risk of that is extremely low. If it does occur, I think we now have a process and technology to very rapidly bring online changes to vaccine, a booster shot that could be quickly approved and be distributed widely. Our manufacturing capability for this type of vaccine has increased substantially. I think the likely explanation or the likely prediction is that we're going to have durable immunity as a society by being vaccinated, or for those that suffered from COVID-19 via natural infection. I don't think individual risk is going to be zero. People who are immunocompromised, people who are very old will still be at risk of contracting illness and will still be at risk of hospitalization. But if we can get our vaccination rates high enough and prevent endemic spread, then we can limit the amount of risk to those people. So that's my my predictions, my presentation. I'm sorry if there was a little clunkiness with the video there. With that, I'm happy to take any questions and try to look at the chat here and see what people have to say, and I'll do my best to answer them.
Thanks, Mike. So actually, yeah, I think we don't have any questions in the chat.
Oh, good.
And this has been a great, thank you for painting this picture of kind of where we are, where we've been, and where we're going. I had a question I was going to ask you, and you got to it at the end there about kind of what your predictions are looking forward. So I certainly thank you for sharing that. It's just past 8 o'clock. And so what I would ask though, if just very briefly, if you could just share, so if anybody does have a follow-up question or searching for more information, can you kind of point us in a good direction to learn more, to read more, to find out more? What's your favorite go-to resource?
Yeah, so I think it depends exactly what you're looking for. The CDC website, I think, is very good. It's a little bit difficult to navigate, but in terms of getting detailed, simple, either simple or detailed information about the vaccines and about some of the current public health strategies, that's a website that throughout most of the pandemic I was visiting on a daily basis. And so I think that is a very good resource. The VDH website has come a long way and also has a lot of very good information, including where you can get vaccinated if that's a concern for you. I think that's a good website to go to. If you want to look at the data yourself and look at what's happening around the world, Johns Hopkins has a website that allows you to easily surf around and look at information. The New York Times website I also have found to be very easy to look at if you want to look at what's happening state by state, whether it be vaccinations, case rates, things like that.